PowerPoint and start with the first slide. Like, okay,
Okay. So now I
yeah,
have to be in PowerPoint, right?
yeah,
All through my lecture. I don't need to be in OBS.
no,
Okay.
yeah. Come back to PowerPoint. Okay, you start, sir.
Okay. But then I won't be able to see the screen if I.
No, no, sir. Actually, you need to teach. Hello.
Ah, yeah. Tell me.
Yes, sir. Ac- Actually, sir, you need to teach on this PowerPoint only. Okay, don't
Okay. Okay.
come to Ops. Yeah.
Okay.
Okay, sir. Now you can start.
Okay. Okay. So good evening, everyone. I'm Dr. Kshitish Tambori. Useful evaluative clinical tool that will be used for fundus evaluation. So I will tell you two things. First of all, there are two ways of solving a question. Either you read a question and you get a clue for your options and think of your answer and then go to options. Otherwise, you read a question, mark the important points, then see the options and then come back to the question. So here if you know everything about the question and you know that you're going to get the answer, he's dilated for fundus examination with drops like tropicamide and phenylephrine. So what is the most clinical evaluative tool that will be used for most useful clinical evaluative tool? So for fundus examination, as we know, most important tool is indirect ophthalmoscopy when a patient is dilated, because direct ophthalmoscopy and 90 diopter lens on the slit lamp won't give you a wider view of the entire fundus. Basically, when you need to see the periphery, when you need to see the whole fundus as a whole, you need to use the indirect ophthalmoscope. And ocular coherence tomography is just a device. It's called as OCT. It is used to see all 10 retinal layers and any pathology in that. So basically, a vitreoretina surgeon or a retinal surgeon will always use indirect ophthalmoscopy in cases of retinal detachment. I can't write on the PPT. Hello? 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 So also because of patient's age, patient might have hazy media because of cataract, due to which indirect ophthalmoscope becomes a choice in these patients. Now, whenever you get any question, how do you need to study about the question? I'm going to give some hints about that in today's PPT also. So what is important is if you are seeing all the other options. Now, when you're coming to a point which we are discussing is that how to examine a patient who is dilated for retinal examination. So what are the equipments? We have studied about the indirect ophthalmoscope. Let us study what are the differences between direct ophthalmoscope and indirect ophthalmoscope so that when you come back, when a question comes on this topic from any angle, you'll be able to answer that. Also, know the optics of slit lamp along with 90D diopter magnification and try to know basics about OCT in this question. So, we'll see a basic thing. So, direct ophthalmoscopy gives 15x magnification, that is more magnification, but a very lesser area, that is only 2 disc diopter area will be seen. There's only 10 to 15 degree of the area will be seen. While in indirect ophthalmoscopy, there will be 3x magnification. That is only 3 times of the magnification, but an area of around 9 disc diopters will be seen. And illumination will be limited in direct ophthalmoscopy, while it will be very high in indirect ophthalmoscopy. Stereopsis will be completely absent in direct ophthalmoscopy, and this is a great advantage where stereopsis will be present in indirect ophthalmoscopy. So lesions like epiretinal membrane, retinal detachment, cystoid macular edema, all these things will be seen elevated in the indirect ophthalmoscopy. Even PED like pigment epithelial detachment, all these things will be seen elevated. So the image comes direct and virtual in direct ophthalmoscopy. Indirect, the image is inverted and real. So you need to interpret that in your mind, or you need to interpret it on the paper when you draw it. So the peripheral view, of course, is limited in direct and it's full in indirect. You cannot view anything by the scleral indentation in direct ophthalmoscopy, while in indirect, yes, by indentation you can see more peripheral. So these are some very effective points where any question can be asked to distinguish between direct and indirect ophthalmoscopy, and you can get a MCQ like this. Moving on to next question. A patient 65 years old came with monocular sudden severe painless loss of vision in right eye since one day. On examination, perception of light was noted. RAPD, that is relative afferent pupillary defect, was noted in the same eye. And on fundus examination, box scarring of retinal arteries, veins, and cherry red spot is noted. So, which is your likely diagnosis? There are 2 to 3 hints in the question itself. First, patient is 65-year-old coming with sudden, severe, and painless loss of vision. So, you must know the reasons of sudden, severe, painless loss of vision here. It's only since one day. So, patient does not have any pain on this loss of vision. So his examination, you have noted that vision was only perception of light and there was RAPD. While all the fundus findings were noted, and the characteristic fundus finding that they have mentioned here is cherry red spot. Which of the following is most likely diagnosis? So there are no guesses here to say that it is CRAO. So why CRAO? Because there is sudden loss of vision with fundus changes like box scarring, characteristic cherry red spot, and other options like CRVO is not an answer because CRVO fundus will be very distinctly different. It will be like having more hemorrhages, tomato splash appearance, and methanol poisoning. Yes, there will be sudden loss of vision in methanol poisoning, but fundus changes will not be like this. Fundus changes will be not seen. In the angle closure glaucoma, yes, again sudden painless vision will be there, but patient will have headache, patient can have pain, patient will have trouble, and he will come with lot of symptoms like vomiting or redness in the eye or conjunctival congestion, and all these features will be associated, and it will be a sudden loss, but it will be a painful sudden loss. So you need to distinguish all 3 options from the answer. Hello, Sagar. Anybody is there?
Hello.
Yeah.
Yes, sir. Hello.
Yeah, I was asking you that I cannot write on my PPT.
Is there any issue with the pen tab? No? Okay, sir. Come back to
No,
that
no, no.
PowerPoint.
I
I'll
can.
check.
No, PenTab doesn't have issue.
No, no, sir. Come back to that PPT. I will
Yeah.
tell you what to do. Yes, sir. Click on that review part.
Sorry, where? Review.
Yeah. Sir, then click on that start
Okay.
printing. Yeah. Yeah.
Okay.
Now check once and you can
Sure. Sure.
proceed.
Okay. Yeah. Yeah. Yeah, okay, I can write. So the OBS software disconnected two times, sir.
What, sir?
I think the software disconnected in between OBS software.
No, no, no. It's fine. It's fine. You can continue with that PowerPoint.
Okay.
Okay.
So moving on to the third question, a 30-year-old patient came with redness in left eye since 2 days. He had discomfort and foreign body sensation and mild photophobia. Complaints of seeing colored halos too. So on moving on to examination, there was congestion, chemosis and mucopurulent discharge. Also conjunctival papillae were seen. Treatment was given was catafloxacin drops, 1 drop 4 times per day. There were no steroids given. So what is the diagnosis? So here it is very simple. The answer is bacterial conjunctivitis. Why? Because patient has characteristic signs of bacterial conjunctivitis, that is mucopurulent type of discharge along with conjunctival hyperemia, and the diagnosis for differential diagnosis for colored halos is one of the differential diagnosis is mucopurulent conjunctivitis. So you need to remember in your mind that whenever a symptom comes, you should know its differential diagnosis also, which are very evident and common symptoms seen and very commonly asked symptoms. Like colored halos, you should know three differential diagnoses. First is acute mucopurulent conjunctivitis, second is angle closure glaucoma, and third is incipient cataract. So we are here dealing with the conjunctivitis. So to distinguish from other options, you must know what are the differences that are seen in the allergic conjunctivitis, viral conjunctivitis, and chlamydial conjunctivitis through the following table. So if you see this table, the bacterial conjunctivitis will always have a marked discharge. Viral will have more signs than symptoms, and bacterial will have more symptoms than sign. And allergic will always be mild to moderate with ropey or watery discharge, while chlamydial will always be mucopurulent discharge. So understand this. Apart from that, some good features to remember are there will always be a presence of follicles in chlamydial or allergic conjunctivitis, you can see, while others will not have those follicles. If you see cytological features, viral will have cells, that is neutrophils, and inclusion bodies like cytoplasmic or nuclear bodies will be seen in viral conjunctivitis for pox virus and herpes virus characteristically. So moving on to the fourth question. A patient 71-year-old came with complaint of diminution of vision in right eye. On examination, the vision in right eye was counting fingers at 3 meter. RAPD was present. There was neovascularization of iris seen on slit lamp, and fundus examination revealed tomato splashed appearance with blurred disc margins and multiple hemorrhages. What is the probable diagnosis? So we just saw vein occlusion diagnosis here in the last question, but now what they have given in the options is all vein occlusions and just one CRAO. So you need to distinguish and fix in your mind which vein occlusion is this. Is it a branched vein occlusion? Is it a ischemic vein occlusion, complete retinal vein occlusion, or a non-ischemic complete retinal vein occlusion? So when you proceed, you must know that when there is a branch retinal vein occlusion, there won't be this kind of appearance having uh, tomato splash appearance. Tomato splash appearance is involving complete fundus. So that means that it is a central retinal vein occlusion. Now coming to distinguishing it from non-ischemic or ischemic. So non-ischemic will have a less vigorous appearance. Like non-ischemic will have less hemorrhages, and the full-fledged tomato splash appearance will not seen with the non-ischemic CRVO. While ischemic CRVO, you will see a picture like this. Why will you see a picture like this? Because there is lot of, so it's completely ischemic fundus along with all the hemorrhages in all the quadrants. So answer is ischemic CRVO here, and BRVO will only present with one quadrant of the retina, one vein occlusion. Moving on to the next question. The characteristic retinal hemorrhage shown in the figure is rot spot. This fundus was seen in an ICU patient, and his blood counts were significantly deranged. His hemoglobin was significantly low. Patient has been chronically ill and receiving treatment since long time. Which of the following disease is most commonly associated with this sign? So first of all, what do we see in the given question? We see a sign called as rot spot. Rot spot is a hemorrhage seen like splinter hemorrhage, but it has an area of central clearing. So we can see here there is a hemorrhage, but there is an area of central clearing here. Hello, Sagar. Hello. Hello, Sagar.
Hello.
Yeah, I
Yeah.
was asking you that do I need to? No, this is there. Yeah, okay. So I
Yes,
can
tell.
go into presentation mode now while presenting. No need to be in the.
No, no, sir. No, 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 no.
Sorry,
No, sir. No, sir. Actually, you need to be in this mode only.
here, like I can just click this one, right?
Yeah.
Slideshow view.
No, no, sir.
Because then what is happening? Every slide that
Uh-huh.
I'm changing, I need to again
Uh-huh.
go to pens and select start inking or something like that. I think. No, I think it's happening. Yeah, yeah. No problem.
Mhm. It will be fine, sir. Actually, the thing is that now you need to practice a bit with the pen tab.
Yeah, yeah, yeah. No, but what happens is
Yeah.
when the boxes are selected now, like this,
Yeah.
then it's not this is not coming.
So, sir, you can.
Then
So,
I need
yeah.
to
Okay.
go
Then
to review
I'll
again,
remove that boxes. Okay.
and start
Yeah.
inking again. You
Yeah.
understood?
Yeah. Yeah. I.
Otherwise, I
Okay.
can
So
just,
basically, sir, your network was fine. Okay.
yeah,
Like I can say, like, hello.
yeah. Tell me.
Yeah, sir. Like, actually, I'm checking the network and all these things. So your network is fine, and I can tell you that Prajwal sir can assure or can tell you all the things about that uh, academics.
No, no.
Like,
Academics is okay.
what starts?
I'm
Yeah.
asking you one thing. That is, why
Mm-hmm.
not go in this slideshow view?
Then actually, it will be more difficult for you to change the slides, na?
No, it won't be difficult
Sir, it will be difficult. I am telling you.
because this is more convenient. It's a big screen, and I can write much more.
Mhm.
And also I can
Okay, you
change.
try once.
Yeah, this now I'm in the.
So sir, if you are asking to take the session on this particular slideshow mode, na,
Hmm,
okay, so yeah, so you have to stick in this mode only throughout the session. Okay, you can't minimize the
yeah,
things.
okay.
Okay, sir.
Yes. Doctor, good evening.
Good evening, good evening.
Well, hopefully Sagar has guided you with the technical aspects, right?
Yes, yes.
Yeah. Is it clear? If you have any this one queries regarding to that, you can inquire
Only
before I
one
proceed.
query that should I present in the
Hmm.
this thing slideshow view, or should I present like this with all the slides seen down only?
In the sense, in the presentation mode, or it is in the manual mode, you are asking.
No, no, I don't need to go to the presentation mode. There are no notes or nothing like that. But the
Okay.
slideshow mode gives a bigger screen to me so that the
Hmm.
writing is more and also the changing is easier.
But the doctor, what I feel now, whatever the thing may be, it doesn't. There is no issues with the screen actually. In the pen tab, there is a fixed area where you can write actually.
Okay.
In pen tab, you can't operate this one. In each and every area, you can't write actually. There is a fixed
No,
area
that is
where you
okay.
can operate.
No, what is happening is now if I
Hmm.
write here, suppose, and if I go to
Hmm.
select this,
Hmm.
uh, if there is a, what do you say? Now, if I change the slide and I
Hmm.
go here and the box gets selected by mistake, the text box,
Okay.
then I
Okay.
have to again go to review and click to start inking and then it will write.
Okay.
That
Okay.
thing
Okay.
will
Okay.
not happen in the slideshow view.
Or else, what we can do is we need to convert this PPT to PDF.
That no, that is okay. So I can remove the boxes also, no worries. I was just giving a easier option. It's okay,
Yeah,
no problem.
you don't have issues with any of these things. What we need is you should be comfortable. That's
Yeah,
all.
yeah, okay, okay,
With whichever you are comfort, you can use that.
no problem. I'll just see
Yeah.
when I practice myself. I'll just see both the things.
Yes, yes.
No
Because in
issues.
front of the screen, you will be presenting and you should be comfort, right?
Yeah, yeah, sure, no problem.
Yeah. So, doctor, your session is for 26th, if I'm not wrong, and it is 1.5 hour session for 25 questions.
Yeah,
And before you proceed, doctor, you need something to give introduction for Medicos community platform itself.
yeah,
Like when you go through this one, Medicos community's previous live sessions, different doctors they have introduced the Medicos community and they have this one proceeded ahead with the first question.
hmm,
And the thing is that for previous session we have classified the session into two parts.
yeah,
Like it was 13 questions and 12 questions, something like that we have classified. But with ophthalmology, I don't feel we need to classify directly. Let it be 1.5 hour session, and let it be 25, so that you need not say those statements in your particular presentation. And what you'll be doing is you'll be giving the introduction for the medicos community, and directly you'll be proceeding with the question number one. And
yeah.
you know how interactive you should be, and you should check the chat box. Whether Sagar said you something like how you are supposed to check the chat box.
No,
That is, doctor. Actually, you need to open the medicos community YouTube live channel when you are presenting the, yeah, in your phone, not here.
okay, okay.
In your phone, you should open this Medicos Community YouTube platform where
Hmm,
your session will be live,
hmm,
and you mute down that particular session in the phone,
okay,
and you just go through the live chats which are happening.
okay.
Okay, and come back to that PPT, come back to that PPT, doctor, once.
Yeah,
Come to fourth slide, what it is.
this one.
Yeah.
Yeah,
Here, this particular thing is now, doctor, kindly replace the differential things,
yeah, yeah.
because I hope you have taken the screen, this one photo of the
No, these
particular
are
book
my
or something like
handwritten
that.
notes, but
Yeah,
I'll type it. I'll type it.
yeah, it is like doctor. It is something like quality is compromised,
No,
I
no.
feel.
I'll
Yeah,
that is only one slide. Rest
yeah,
everything
okay,
is written only.
okay, okay. Kindly replace this particular thing, and
Yeah.
you update us, okay?
Yes. Yes.
And what you are supposed to do is, doctor, you don't this one. We will be in the connections only via WhatsApp
Yeah.
when your session is live,
Yeah.
and you should keep your particular telephone in the vibration mode actually.
Yeah.
And this one is why I'm saying it should be in the vibration mode, because you should not talk anything, or you should not use that particular telephonic conversation when the session is live.
Yeah.
because when if we talk something via telephone when the session is live, it will be highly risk factor for us, like we need to edit the particular whole video and it will be time consuming.
Sure.
So you should not use that particular telephonic conversation at any time when the session is live, but we will be in the connections via chats, this one WhatsApp. Okay.
Yeah.
And come back to your op software doctor once. Sagar, are you there? Sagar, am I audible?
Hello. Yeah, sir, you are audible. Actually, I'm trying to speak in the muted only.
Okay. Here I can see the grayish thing in his background,
Yeah, yeah, yeah. I have seen that.
and that particular chroma screen is not adjusted properly, and the brightness is not proper,
Hmm.
because you can see many disturbances over his face, even though you
Yeah,
have properly
I have
magnified the
seen. I
thing.
have seen.
Yeah,
Actually,
those
sir,
things.
I was checking for the network because in the
Hmm.
starting I feel that it won't work, na?
Yeah, network is fine, na?
Yeah, network is fine.
Because I haven't checked it today. That is why I am asking you. And the thing is, whether the, doctors this one back in chroma screen, is it proper, or is it something there is issue with that particular green color? Sagar, am I audible?
Yeah, yes, sir, you are audible.
Is a proper green screen, is it proper, or we need to change that
Is
green
it
screen
proper, sir?
also?
Actually, we need to
Huh.
add more lights to it, as always say.
Okay, okay, okay. So, in the sense, you need more light in front of him, you are saying.
Yeah.
Okay. So we have one more this one particular training session on 25th, if I'm not wrong. Am I
Yeah.
correct, doctor? It is on 25th, right? Yeah.
Yeah.
You please correct those things what it is recommended by Sagar, like brightness and additional factors.
Okay.
And Sagar, have you corrected that particular brightness with Kshitij actually? Have you used that
Mm,
brightness option?
no, no, sir. Actually, the thing is that now the similarity is not working. Like I can say
Hmm.
the
Hmm.
green screen is too light,
Yeah.
In the
And
sense, it is parrot
and I
green.
know.
What green it is?
Yeah, it's parrot green, and the thing is that na, yeah, the lighting condition is not proper, na, sir. We need to add more lights to it. I can say
Okay.
particularly the yellow lights.
Okay, in the sense I am asking you whether doctor needs to change his chroma screen or whether you are asking to add more brightness. What option is preferred?
I'm asking to add more brightness to it.
Or
you
he need not change the chroma screen, right?
No, it will
Okay,
work.
you want
okay.
the yellow light in front of me?
Yeah, if possible, sir.
Okay.
Yellow in the sense you are saying ordinary light, if I'm not wrong.
No, no, sir.
Yellow.
Actually, I'm asking about the warm lights.
Acha, okay.
Should I bring one? I have a lamp, yellow lamp. Should I try that?
Sagar, are you there? Sagar, am I audible?
Yeah, yes, sir. You are audible. You are audible.
He's asking something regards to that light which he needs to
Yeah,
get.
yes, sir. Please tell me now.
So
Yeah.
I have a yellow color bigger lamp. Should I get that and try?
Yeah, yeah, yeah. Yes, sir. Please bring that.
Yellow or white, Sagar?
Sir,
White
I'm
is
asking about the yellow.
white is
Okay, okay.
already there. The bigger white light that I put right now.
Okay, okay. Bring yellow. Let us see.
Can you see?
Sagar, is it proper? Like I can see, but shadow is visible. I feel right. Sagar, are you there?
Hello.
Yeah,
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 yeah, I'm
yeah.
there. So
Check
yeah,
it.
sir. So yeah, yeah. Tell me, sir. Tell me.
No, can you see? He has used that yellow light which he has got.
Mm-hmm. Yeah, I can see. Sir, so
But
yeah, click on that video capture device once and open the filters. Yeah. Then keep it to 415 once. Sir, can you place this light behind you?
Behind me.
Yeah. Like I'm asking to place it only to the green screen.
Just
Sir,
yeah.
can it be placed in the center of that green screen? Can we expect that?
It's difficult, but
Mm, no, no, sir. Wait, wait, wait. I'll tell you. I'll tell you what to do. Sir, place it in a distance.
better, better now.
Okay, then you close this one once.
Yeah,
No, no, sir. I'm asking to close this
yeah, yeah.
particular tab only.
Yeah.
I can say like it's better, but not good to go. Okay, sir. Then open the filter once again. Yeah, click on that chroma key and you keep it to 405. Mm, okay, but we need to fix it. Actually, sir, do you have one more light?
Uh, yeah, but that portable light is not charged now. I'll
Okay,
charge it.
okay, no issues.
Yeah,
So, sir, can you bring it after? I can select tomorrow or when we have the session.
yeah, yeah. I'll bring it.
Okay, no issues for that. And sir, right now you are using a webcam or a laptop cam?
Laptop cam.
Okay, sir. So actually, the thing is that now I don't feel like the quality is too good. So in the further future, we may need that webcam. Okay, so for this time, we will do it with this proper lighting. Okay, I will set it. but for the further future, we may need that webcam.
Okay.
Yeah. Yes.
Is it because Sagar that he has changed his laptop?
Yeah, yes, sir. Actually, the thing is that na, the camera quality is,
No, but because why I'm asking now, previously when we have checked, you have agreed with the camera part of Chitish
sir,
actually.
actually that time sir was using the Mac, na.
Yeah, yeah, yeah. But this is which laptop,
This is HP.
Chitish?
This is HP.
Yeah, yeah, yeah. Hmm. But the thing is, Sagar, what I feel now, before we use any kind of webcam, I feel with the brightness we can go ahead because the same problem we have faced even with the Dr. Ramya actually.
No, no, sir. Actually, the thing is, I can say like not with the brightness.
Hmm.
Actually, actually, sir, yeah, yeah, yeah. I
Hmm.
can just say like they are the minor settings.
Hmm. 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 No, Doctor,
Yeah.
you increase the
So
magnification of your image once. No, 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 no. It's bit more, bit more. अच्छा, okay,
मतलब
okay, okay.
होता है ठीक है.
Hmm. Yeah, it's the issue with that particular webcam. Yeah, camera quality is not so good of this particular laptop. I feel. Yeah. Hmm. Yeah, doctor, we may need one webcam for this in the further future, but not for tomorrow's session or day after the upcoming session.
Okay.
Because here the thing, na, or you need to get one laptop with these specifications and the good camera. Whichever is a good part, you need to think.
But again, changing a laptop, no problem. I will see. I'll see about webcam next.
Yeah, yeah, yeah. Sagar, so doctor, what we'll be doing is you need to practice with this particular pen tab
Yeah, yeah, I'll do it.
for the upcoming session, and it is not so easy to write on the pen tab. I feel.
Yeah,
And one more thing is. You need to submit this particular PPT after next training session. You need to submit for editing actually.
yeah, yeah. Okay. That is on
Like
25th.
what? Yeah, you can
Yeah,
submit that for editing, and we need to add the watermark, etc. Yeah.
yeah, yeah. 25th, I'll submit. No problem.
Yeah, and you change that fourth slide. Okay, you change that
Yeah,
fourth
yeah, yeah.
slide.
That is just. I'll change it.
Yeah. So, Sagar, do you have any issues? No, right?